Om Shahana Bhavatu Shahana Shanti Shanti. Good evening, everybody. So today, Sreyoshi ma'am will start, right? So, oh God. Sreyoshi, I am making you host. Okay, Sreyoshi?
Yes, sir.
I am making you host,
Yes,
so
sir.
now you can
Yes,
manage.
Sir.
Okay. Now you can start.
So everyone has joined. Who has joined? Darsh is here. Priyanka Shaha is there. Shudipta Mojumdar is there. Okay, only two are left. Okay, so I'm starting. So, good evening, students. Today, me and Priya ma'am will teach you how to take case history and a mental status examination of a client, right? And you already know that you have to submit 10 cases, okay? 10 cases, 10 case history and MSc format and screening format. So you have to submit for practical purpose, right? So we are planning that today we will discuss how to take case history and mental status examination. So then you and I will provide the format also after the class. So before that we will discuss whole procedure, right? Online, right? Telemental health, because you are doing telemental health counseling now. So before planning the intervention, you have to take the case history and MSc. Okay, so before going to the format, I just tell you why it is important to take a case history of the client, right? Because first, you guys can tell me why it is important to case history and mental status examination before planning the intervention and starting the intervention with the significant persons. So, what are the ideas you have? Why it is important? So, who will tell first?
Pardon me, ma'am. Can I ask one question?
Yes.
Actually, I was trying for the last 5 minutes to join, but nobody is allowing me to join. So I have missed the initial words from you. Can you repeat, please?
Yeah, actually today we will teach, me and Priya ma'am will teach how to take case history and mental status examination of the client, because you are the budding telemental health counselor, right? So before going for the further intervention and planning the intervention, and so before that you need to take the case history of your client, right? So just in initial things I said. So my question is that, what do you think? Why it is important to take case history before planning your intervention strategies? Why it is important to take the case history, and what do you know about the case history?
Am I permitted to answer the question?
Yes.
Ma'am, without having the case history, how can we focus our work on that client? Hello?
Hello?
Am I audible properly, ma'am?
Yes, you're audible. You are audible.
Taking case history is very, very important to know the basic background of the client and in what position, in what mental state he or she is belonging now, and what will be my aim or objective to work with, and what will be my goal to set up the goal and know the whole about the client. We have to take the case history first. And as I am not a psychiatrist, so if there is any suggestion from prescribed psychiatrist, prescribed suggestions, that will also guide us to work with. That is my idea on that, ma'am.
Okay, very good. Fine. Anybody else?
Yes, ma'am.
Yes.
Ma'am, case history is actually very important because it gives the a clue about the client, what exactly he is going through. And if we get to know about the health, the problems, the diseases that he is having, so it may help the counselor to know him better and to make a proper plan for him in counseling.
Okay, very good. Anybody else? I hope you all participants should share their views. So next.
Yes, ma'am. Actually, this helps the counselor to know about the counseling. What kind of problems, from what kind of problems or what kind of psychological pain he or she is suffering. And another thing is the prognosis. Actually, from the case history, we can get some pictures about the disease or about the his or her sufferings, and we can make the roadmap how to treat or how to handle the case, or how to give advice to this patient.
Okay. Okay. Next.
This is a very vital thing to make a clear picture of the counseling. It is helpful to make the treatment plan or counseling assessment
Sudipta,
plan.
I can't hear you. Your voice is breaking to me. So can you say it again?
Hello.
Yes.
Am
Please
I
say.
audible, ma'am?
You're audible, but your voice is breaking. I mean, just again.
Case history make a picture, total picture of client that helps the counselor to make an assessment and goal setting about the counseling.
Okay. Okay. Very nice. So my next question is, before planning the, you all are saying that it will help us to make a planning for counseling, right? So what is the first thing before planning the counseling? What is the first thing we can do on the basis of case history? Think. What is the main thing before planning the counseling? What is the main thing we can do after taking the case history?
The first thing that makes we can do, that is rapport building.
No, that is okay, case history, but on the basis of case history, what is the primary thing we can do?
Ma'am, after knowing the case history of a person, of a client, we can set the short-term and long-term goals about that client.
It will help us to make the whole counseling intervention procedure right. But what is the primary thing? What is the primary thing?
Assessment about the counseling.
How do you know what kind of assessment you need to administer? How do you know?
We can make a primary picture with this case history, and case history. After taking case history, we make a we can plan the what kind of test or what kind of test or assessment that we can make with the client?
Acha. Acha, Dr. Priyanka, because you are a doctor and you are a homeopathy doctor, so while you are prescribing any medicine, how do you know what kind of medicine you should prescribe? Because initially you are a doctor, you should take a case history first, right?
Yes, ma'am.
So
Yes.
how do you know, what is the primary thing after taking case history? What is the primary thing that prompts you in your mind?
Ma'am, actually, this gives some ideas. The
Ideas about
roadmap.
what?
Idea means
About
idea
what?
means the sign and symptoms gives us the provisional diagnosis.
Very good, very good, very good. So primarily we are doing the provisional diagnosis. After taking case history, we are doing the provisional diagnosis, and on the basis of our provisional diagnosis, we will plan what are the assessment we will do, and how to plan the whole counseling process, how to plan what are the strategies we will implying during the counseling process. So before that, the diagnosis is very. So maybe while you are seeing a client, and the client will stating you some signs, okay, some complaints, and on the basis of that, you will think what are the provisional diagnosis would be. On the basis of that, you will plan that the patient may having some anxiety issue, so I will assess the severity of anxiety, then planning the strategies of the counseling. And if you are thinking on the basis of chief complaints, then the client may have depression kind of the client may have depressive episode. So first I have to assess the severity of depression, then I will plan short-term and long-term goals and the counseling strategies. Okay, so case history primarily help us to make a provisional diagnosis, right?
Madam, yes, madam. I just want to add one thing, and it is in my mind, so I just want to tell it now.
Yes.
Yeah, actually, in case of any medicinal treatment, there is some prescribed drug for maybe if from homeopathy or allopathy, in whatever the treatment procedure, there is a prescribed drug for each and every disease, and we can apply this. But this type of therapy needs constant improvisation, because one therapy is maybe not working good for another client. Is it, madam?
So the case history will help you what kind of therapy you can plan for the patient. Okay, so case history is very important thing, right? Okay, so I'm sharing the format. Okay, Priya ma'am, would you like to share your idea about case history?
Yes, am I audible?
Yes.
Okay, so case history, a detailed case history taking helps you understand how long the symptoms have been felt or experienced by the client. Sometimes our client comes up to us and comes up to a counselor and a psychologist only after the problem has been elevated. And if you go back into the case history, you dig into the case history, you find out that the client or the client is feeling those or experiencing the severity or the less severity of the symptoms maybe 5 years ago, 10 years ago. Sometimes even in childhood, they might have experienced some anxiety or some issue, but earlier it was left untreated and now it has the symptoms and the severity has increased. The case history also helps you understand what kind of symptoms and the severity of symptoms have been experienced by the client, and what are some major issues and some major life events helped in contributing in those symptoms. So the detailed case history, the interpretation of those events helps us understand the holistic picture. So when we are completed with the case history and we have taken all the details from various sources, we have a total picture of our client. On the basis of that, we can plan our treatment and our interventions. So I think that is my basic idea about the case history.
Okay, thank you, ma'am. Thank you. I hope it has been understood by all. Okay, so I am sharing the format with you all. Okay, and one by one, I am describing about that. Let me share the screen first. So it is visible. My screen is visible.
Yes, it's visible, ma'am.
Yes, ma'am.
Okay. So this is the main format. Okay. So actually, but it is a very comprehensive model of case history. I will send you after the class. Okay. Okay. First, when a client, first time when you meet your client, so firstly, what you will ask your client about their socio-demography detail and the some identification detail. Okay, so here you just need to write 1 to 2 sentences about your client's age, about the name of the client, the gender of the client, age of the client, where the client is residing, their marital status. If the client is adult, okay, above 18, if the client is adult, so marital status is very important to note, and the mother tongue, because mother tongue will help in which language you will communicate with the client. Okay, their educational qualification, because educational qualifications help you what kind of vocabulary you will use during the counseling procedure, right? Suppose one is coming from rural area and one is coming from urban area, okay, very high socioeconomical background. So both of them, you cannot use a similar kind of terms, similar kind of vocabulary, right? So it may the educational background, the marital status, okay, it will help you, and where the client is residing, it will help you to make a plan in which way, in which term you will communicate with your client, right? Then what kind of family type she is belonging, and the family income. Okay, these are the basic. 1 to 13 is the basic identification detail you have to take from your client when you see your client first time, right? So name, gender, age, address, telephone number. If the client is above 18 or adult, you have to ask about their marital status, the mother tongue, education, the occupation, religion, residence, family type, and their family income, right? And number of the family members also. So on the basis of that, you can understand it is a joint family or a nuclear family or the extended family, right? So without because it is a basic thing, so you have to ask, right? Next is mode of referral, where the patient, why the patient has been sent to you, and what are the reasons the patient is come to you, I came to you, and where who has sent the patient to you. So the referral is very important. Whether the client has come to you because of their self-interest, or any other professional has advised the client to visit the counselor. So source of the referral is very important, and the reason. Maybe client may come to you for assessment purpose, maybe the client comes to you for further intervention purpose. So mode of referral, the source of referral and the reason behind the referral will be taken. Next, obviously you note that because case note taken by who is taking case history. So you are taking the case history, so here you have to write your name. And because you are practicing right now and you have to identify what are the strategies you have to implement in future, and so whom you are discussing your case. So next column is discussed with, so you have to write the faculty name, right? So next is any identification marks of the patient, any identification mark that highlighting the patient. Okay, so the identification mark, it is not mandatory. It is not mandatory, but you can write any cut in his face, any wrist cutting you have find. So this can be an identification mark of the patient, right? And the second part is very important, that is informants detail. Informants details, who has I mean, informant maybe their parents, maybe their husband, their wife, their friends, other family member. So they will be inform you about the history of the client, right? So informant's name, write the informant's name, and what are the relationship with the patient you have to mention, and duration, like if the client, if you are seeing a child, right? One second, you are seeing a child. One second, just a moment, my computer is showing it is low battery. I'm just put it on charger. I'm coming back, right? Give me just 2 minutes. Sorry. Okay. Okay, thanks for waiting. Next is what I'm saying. You have to mention the informant's name and what kind of relationship you have to mention, and the duration of relationship, that if the patient is come with their parent, right? So how long they are living together. So duration you have to mention. Okay, and the duration and continuity. Sometimes you can see that the child is sent to a boarding school for some appreciable period of time, for 5 years, 6 years. So the continuity break. Okay, so you also take record about the continuity and the duration of that relationship and continuity of stay with the patient, right? And the consistency and coroborativeness of the information provided. Okay, because sometimes you can see that the patient stating some problem and their informant stating another kind of problem. So it means that there is a no consistency between their verbatim, right? So you have to if the information you are taking from both of the parties, if they are not similar and corroborative, so you have to mention. If the consistency and corroborativeness was not found, you have to mention that non-corroborative or non-consistency was reported. And if you find yes, it is consistent, the patient party, what the patient party are reporting, and what the information given by the informant, so they are corroborating you, then you can write yes, the informations are consistent and corroborate. Okay, then is reliability and adequacy of the information. So the information you are getting, whether it is reliable or adequate, you have to find out. So how it will be fine. You can ask the family member and not family member and the patient, and if Same. If the informations are changing session to session, that means reliability is lacking, adequacy is lacking. Okay, but if the informations are same throughout the session, every sessions are informations are providing in a same manner, so it means the informations you are getting, that is very reliable and adequate, and the information the patients is giving you and the informants are giving you, so more or less they are similar, so you can say that information are quite reliable and adequate, right? So any questions? Any questions you can ask, because this is very important thing. Okay, no questions, I guess.
Ma'am,
Yes.
as you told about the last 2 points, consistency and coroborativeness of information provided. If we see that it's the consistency is okay, so do we have to leave this or we have to write something over here?
You just read that it is informations are consistent and corroborate. Just you have to write in that.
Okay.
Okay, now you have to take the presenting complaints in a chronological order and duration. Okay, so what is the chronological order? How to write that? You have to write first noticed by patient and their family member first. Okay, sometimes suppose some informations like patients are reporting I'm feeling low, one complaint. Second is reduced energy, reduced physical, I'm feeling reduced physical energy. Okay, reduced appetite. Okay, reduced need for sleeping. Okay, so these are the second problem. Next problem, next complaints, they can report that that the patient may feel like does not want to interact with others. Okay, this is the third problem. Next problem, patient may complain that patient may complain that first I just need to write that, then it will be feels low. Okay, first problem. Next problem is reduced energy. Okay, energy. Next maybe does not next maybe does not want to does not want to interact with others. Okay, and next like fourth one may be trouble sleeping. Okay, next may be difficulty concentrating. Okay, difficulty concentrating. Okay, so these are the 5 problems patient reported. Okay, so the you have 5 complaints. So then you have to ask from when you are facing these complaints. So patient may report that feels low since 2 months. Okay, reduced energy feels since 1 month. Okay, does not want to interact since like 5 like it is also 2 months, for 2 months. Okay, trouble sleeping for 3 months. Okay, difficulty concentrating for 1 week. Okay, so in that way patients are reporting. So but you have to make the symptoms in a chronological order. Yeah, first you have to note what are the complaints patient are reporting. Patient is reporting, you note it down, then note the duration. Note the duration. You have to write, then make it in an order, chronological order. So how to make a chronological order? you have to find out which symptoms was coming first. So here is the trouble sleeping. Trouble sleeping is noticed by the patient first because it has been for 3 months, right? So chronologically, you have to write the symptom which has been noticed first by the patient, right? So because trouble sleeping is noticed by the patient 3 months ago, so you have to write in number one column. Okay, so you have to write it number 1 column, like trouble sleeping for 3 months, right? So tell me which symptom, which complaints will come next. You get my point? You get my question?
Yes, ma'am. From how long days, depending on the duration.
Right.
3 months থেকেও যদি বেশি কেউ হয়, means 6 months, suffering from 6 months, that will be first one.
No. Yes. I'm highlighting this. Okay, I'm highlighting this.
Okay, ma'am.
Okay, these are the your patient, right? Initially, these are the symptoms or these are the complaints are reported by your patient, and then you take the duration, how long the patient is suffering from this complaint, right? So you have noted by you, and durations are noted by you, right? Then you have to arrange the complaints in a chronological order. So what is chronological order? Which symptom has been noticed by the patient first time. So in this, these are the complaints. Here, trouble sleeping is for 3 months. That means it has been noticed by first. Right?
Yes, ma'am. I am just wanted to tell, the more the older the symptom, that will
come first. Then gradually,
yes,
then gradually
the newer one, from older to newer one.
Exactly. So here, which symptoms will come to next?
Feels low. And doesn't want to interact with others.
Exactly. So I am copying this. Okay. Okay. Very good. Okay, then which symptoms will come to next?
By mistake, you have done the reduced energy to the second point. You have
okay, sorry.
That will come for the fourth, as a fourth point.
Yeah, thank you. Tell me which symptom or which complaints will come to next.
Fourth will be reduced energy.
Yeah, fourth will be reduced energy, right? Okay, then it is reduced energy will next.
The last one will be difficulty in concentrating.
Yes. Right? Okay. So very good, Darsh. So these are the way you have to present your complaints in your case history format. First, you have to know what are the complaints the client is reporting. Then you need to ask the duration of these complaints, and then you need to arrange the complaints in a chronological order, right? So you have taken this first, then the duration, then make it in a chronological order. This is the final outcome. Okay, same thing. So firstly, you have to take the complaints from your patient, and then you take the presenting complaints from the informant. right? So up to this, it has, you understood, you understand all these things?
Yes, ma'am.
Any question? Okay. So after taking the presenting complaints, so you have to write the history of the illness. Okay. So history of the illness, it is very important. History of the presenting complaint. So it is a description of the current complaints that the client has. Okay. So but this require detailed elaboration, often using the person own words and supported by the relevant functional inquiry. Okay. So even what is the precipitating factor? Precipitating factor is the main causal factor of the complaints. Okay. What leads to feel the patient in that way? What leads to feel patient in that way? Because sometimes, because here, sorry, here we are recording, we were all, sorry. So we recorded that these are the symptoms, these are the complaints the client already reported. Okay. So feels low, does not want to interact with others. So what makes the child, what makes the client feel in that way? What are the causal factor behind that? What are the causes behind that? So you have to find the causal factor. This is the precipitating factor. So you have to write in 2 to 3 sentences in this column, precipitating factor in this column, right? And the mode of onset, sudden onset, if the symptoms are noticed within 48 hours, so you have to mark the sudden or abrupt onset of, or if the complaints were noticed within 2 weeks, then you have to mark the it is as a acute onset. And if the symptoms were noticed more than 2 weeks, so you have to mark the insidious onset. If it is noticed within 48 hours, you mark the sudden or abrupt onset. Within 2 weeks, acute onset, or more than 2 weeks, it is insidious onset. So tell me about the onset. What kind of onset? What are the mode of onset for these problems? Insidious, acute, or sudden?
Ma'am, it's insidious for all except the difficulty in concentrating.
Exactly, exactly. And for concentrating, what is the mode of onset?
It is active, no, actual, sorry,
It is
acute.
acute,
Yeah,
right?
acute.
Okay.
Yes, ma'am.
Okay, very good attempt. And then you have to mark the course of the complaints, whether it is continuous, episodic, and if it is unknown by the patient, though you have to mark the unknown, right? So the same complaints were reporting by the client, it is continuous or it is episodic. Okay. And the progress of the symptoms, whether it is deteriorating and improving or fluctuating. So you have to mark the progress of the complaints, right? Then hello.
One thing I want to ask.
Yes.
As you have mentioned your course, that is continuous, episodic, and not known. This is for the all over symptoms or for each and every symptom we need to know?
All over symptom and each and every symptom.
Achha, both the cases. If you have mentioned 5 symptoms like feel low, reduced energy, so we need to see that if feeling low is continuous, episodic, or not.
Exactly.
Okay.
Exactly. Okay. So then you can write in this blank space, what are the other things, what are the impact factor, what are the coping strategies patient are using while dealing with these complaints, right? So you can write the detailed case history, detail the history of the complaints in the blank format. Okay. So coming to the next. So next is biological functioning. Biological functioning, you have to ask the your client that their sleeping habits, their appetite habits, whether it is unchanged or increased or decreased. Okay, so you have to take the details about this biological function: sleeping, appetite, sexual interest and activity, and their physical energy. Okay, because mainly you are seeing anxiety. We will teach you the how to counsel the anxiety and depressive client. So in these cases, you can see that some depressed patient will reporting that their sleeping patterns are increased. Okay, or their sleep they have trouble sleeping. They have trouble sleeping. They face difficulty while sleeping during night. Okay, or in case of appetite, they may report it that they are taking more food, or they are refusing the food. Okay, their sexual interest and physical energy also reduced or also increased. So these are the biological function will be reported by the client. So you have to take the information. Even in this describe portion, you can write that sometimes patient will inform you that after taking medicines, their sleeping habit gets better. After taking medicines, their appetite gets better. Okay, after taking medicines, their energy, they feel more energy. So you can describe what are the causal factor between about the increment on decreased sleeping pattern or appetite habit, right? So you can describe here. Or unchanged, the patient will report you that there is a no change in their sleeping and appetite and sexual interest and physical energy, right? Sorry. Next, you need to take past illness. You need to take past illness. Here, you need to record any medical things, any medical physical symptoms, physical, not psychiatric, physical symptoms or any severe physical symptoms they already faced in past, and they already seek any treatment for their physical illness, or what are the outcome of the was in past. Okay, so you have to mention in the medical column, right? And in psychiatric, because or in first class, while teaching you the counseling process, I have mentioned that sometimes relapse may occur. Okay, because while treating the psychiatric patient, we cannot say that you will be cured, you will be 100% cured. We cannot say, because relapse may occur. Why relapse can occur? Because stressors are there. Okay, so sometimes the patient who are feeling depressed right now, they also have depressive episode in 2 years ago. So this is the past history, right? So you can write the past history that you are facing the problem right now. Okay, so in past, whether you have any psychological or any physiological illness you already faced in past, so you have to mention what are the diagnosis and what are the medicine you have taken and what are the treatment you already seek and what are the outcome of the treatment. Okay, so this in this column you have to mention the medical history and the psychiatric history, right? Okay, next you have to take the family history. Family history, you need to take family tree, 3 generation family tree. Here you have to take the name. You have to make a family tree. Family tree, right? Like a patient. Patient is belonging from who are belonging from their paternal family and who are belonging from their maternal family, and anybody in their family member, anybody in their family already suffered from any physical or any psychiatric problem, so you can note in this column, right? Okay, next is family interaction pattern. Sorry. family interaction pattern. So what are the family interaction pattern? Is there communication pattern? What are the communication pattern in their family? Sometimes there is a very open discussion, open communication pattern, and there is a very indirect communication pattern. Like if I want to say something, I want to get some permission for my father, I used to tell my mother to get permission from my father. Okay, so this is very indirect communication pattern. In some family, you can see that the patient want to get permission for anything. They can go to their parents, they can go to their father and take the permission openly. So what are the communication pattern in their family? Leadership means what are the...
Ma'am, please once again explain that communication part.
Okay. In communication pattern, you can find out what are the communication strategy they are using. Whether there is a very open communication pattern or there is a very direct or indirect communication pattern. In case of direct, I can ask you, Jadarsh, you can do a favor for me. So this is very open and direct pattern of my communication. And in case indirect communication pattern, I can ask Priyanka to get some permission from you. Okay, so it is very indirect communication pattern, right? So these are the what are the communication pattern the family members are using, right? You understand?
Yes, ma'am.
Okay. Okay. Next is decision making leadership strategy. Sometimes in case of family member, sometimes there is a one family member who will make the decision for all others. Okay, suppose the head of the family member, maybe the grandfather, will make the final decision for all. Okay, and in case of other families, you can see that decisions are made through discussion. Through this discussion, the decisions were made. Okay, so what are the strategies are using while making decision? Is there is a participatory approach or is there is a very authoritative approach? Okay, in case of authoritative approach, there is a one family member who will take the final call for all the family members, and all the family member will have to do in that way, right? But in case in other families, you can see that the decisions are made collaboratively. Okay, so and the leadership pattern, who lead the whole family member while any kind of positive and negative situation arise, who is the primary family member lead the family. Okay, next is role of the client in the family. Role of the client. Suppose in case sometimes family, the client who sometimes you can see that client may report that he or she is not contributing something to his family, right? And sometimes family, the client say that he is the only person who take the all responsibility. Okay, so the client maybe feel burdened by the all responsibility, right? So what are the roles are maintaining by the client in family, right? So you have to mention the role of the client in family, right? Next is family ritual. Is there any significant rituals are performing by the all family members every day or every month or every week? Like the families used to go for an outing, for a dinner every Sunday. So it is a ritual, right? And sometimes family, the client may report that all family members are used to go for a vacation once in a year. So this may be their family ritual. Okay, or once maybe other family member, other client may report that there is a particular time every day that they used to go to mandir for pray, right? So what are the family rituals are maintaining by the all family member of the client? You need to ask, right? Next is cohesiveness. Cohesiveness, this maybe it can be that cohesive, like the client family member are very cooperative to each other, right? So whether the each and every family member very cooperative to each other, you have to identify that. Okay, so in the cohesiveness you have to write the whether the family member are very cohesive and they are participating, they are doing a task very collaborative manner. Okay, they are cooperating with each other. Suppose I am facing any problem, so my other family members are come to help me. Okay, so these are very cooperative and cohesive things you can elicit, right? Family burden, in case of family burden, you can elicit the what are the burdens the client and every family members are facing. Suppose this can be a financial burden, and this can be that there is a one person in family is already diagnosed with a terminal disease or very severe illness. Okay, so they are facing some caregiver issue, caregiver burden. So what are the family burden they are facing? Okay, next is expressed emotion. Expressed emotion, like sometimes in family you can see that every persons are very loving to each other. Okay, sometimes in other families you can notice that every family member are very hostile to others and saying very critical comments to others. Okay, and in case of other families you can see they are very over involved. They are very over involved, like your mother is very over involved. What are you doing, where you are going, and what are the things you are buying, why you are buying the things. So they constantly scrutinizing all the things. Okay, so they are very over involved, right? And what are the reinforcement factor the family members are maintaining, right? So these are the expressed emotions. So why it is important to note? Because if you see a depressed patient or any anxious patient, if their family member constantly saying critical comments the client, showing very hostile attitude towards the client, and do not and very overly involved, emotionally over involved towards the feel very burdened. Okay, patient may not feel independent. Okay, even in case of if the patient is adult, so what they are expecting, say that he or she is very able to take their own decisions, but the decision at the age of 30, the decision is making by their parents only. So this is very demotivating for the client. So these factors may lead the client to getting more distressed and anxious. Okay, so that is why this the communication strategy, communication pattern, family interaction pattern should be noted by you. So it will help you understand the family etiological factors, right? What are the etiological factors from the family environment makes the patient to feel distressed and anxious, right? Any question? Please ask. Or any detailed elaboration you want, please ask, because it is
Ma'am,
very
above
important.
this point, the family interaction pattern. Above this, there is a point, consanguinity in patient. Can you explain it?
Consanguinity, right? Like in some group, there is a any relationship between in their family, like any marital kind of relationship happen in their family. Okay, like suppose in some relation, in some family member, in some family, in some religious group or any culture, you can see that in a family the their aunt, like in that way. So there is any marriage in a blood relationship. So this is the consanguinity you have to find out. Any
Okay.
marital relationship happen in the blood relation. Okay. Anyone else who want to ask anything or any detail elaboration? Okay. Next is family history or psychiatric illness. So you have to understand, you have to note that any retardation, any suicidal attempt or suicidal attempt or any substance depends or epileptic episodes happen to the client's other family member, because it will help you to understand what are the genetic factors are there for becoming. Genetic factors are there, because genetic factor is also an etiological factor and will help to make the provisional diagnosis. So you have to identify the psychiatric illness. Is there any retarded family member? Is there any person who have committed suicide or attempted suicide? Or is there any family member consuming substance? Or is there any family member has epileptic episode? Right. So you have to note down. So it will help you to understand the genetic factor. Right. After taking the family history, you have to note the personal history. Personal history, suppose you need to ask the birth or developmental history, but sometimes the patient, for adult patient cannot, if the sometimes adult patient cannot tell that if their parents are not available, they cannot tell that their birth type, whether they are cesarean baby, whether they are normal delivered baby. Those they cannot report. But in case of child, if you are seeing in child case, so you have to write what are the birth type, cesarean delivery or normal delivery or forceps delivery. So what are the birth type you have to identify. In child case, it is very important. But if this information could not be elicited, so you have to write the information could not be elicited. Okay. So next is birth complication. While delivering, there is any birth complication, and you have to mention the milestones for child case. It is not mandatory for adult case, but if you are seeing for child case, you have to identify the milestones like walking, sitting, speech, milestone attempt within time or not, right? Or any childhood disorder. These are the childhood disorder. What kind of childhood disorder you have to take? If it is thumb sucking, bedwetting, night terror, so you have to take. And if the informants or the client not reporting the childhood disorder, so left the column. Okay. Next is what are the relationship, what are the home situation the client is experiencing, what are the relationship, what is his or her attitude towards his parents, and what are the parental attitudes towards the child or towards the client, right? And what are the child or client's attitude towards other family members. So you have to write in very briefly. Okay, you need to write in a 2 to 3 sentence. Okay, not more than that. Next is home situation. Is it congenial, or it is broken, or it is very disturbing? So you have to identify or mark. Next is academic history of the child or the adult patient. So you have to fill this highest grade completed. If like you can studied up to class 10, the client already graduate pass, so you have to write highest grade completed. Then academic performance, whether it is poor or average. And if the client, sometimes you can see the client that the client may not continue their studies after class 10. So what are the reason behind that? Maybe there is a financial problem, maybe there is some IQ problem. So what are the problems? So you can write in the reason of discontinuation. And what are the what kind of the quality of the peer relationship. So the child or client every time abused by their friends or not, or he is very cooperative with their friends or not. Okay, any disciplinary problem like the client or child, or every time every time getting complaints, because he is very restless, he is very abusive, he is not maintaining school decorum. So you have to note it down. And what are the hobbies and interests? Next, in occupational history, this column is important for adult patient, not for child patient. Okay, so the started of working at the age, any job change, so you have to fill the column. Okay. Next, if you are visiting female, so you need to take the menstruation history. Okay, when the menstruation cycle noticed, and whether the cycle is regular or irregular, and duration of the cycle, or any physical and psychological symptoms are associated with the menstruation period. So you have to mention in the column. Okay. So you have any question or doubt, any query? Hello?
No, ma'am.
No,
Thank you.
ma'am.
Okay.
No, no, clear.
Clear to? Okay. Okay. Next is sexual history. Sexual history, you have to identify, you have to note the information, what is the attitude towards the sex of the client, and the current libidinal energy, and the masturbation history, and heterosexuality experience and homosexual experience you have to ask and record in your case history. Okay, because in case of depression, they are reporting that their libidinal energy are reducing. Okay, if you are seeing the depressive patient or anxious patient. Okay, so you need to identify the whole sexual history and record in your format. Any deviant attitude. Okay, sometimes the participant may be very abusive while doing any sexual activity or any illegal sexual activity. So whether the symptoms are present or not, you have to identify and record. Next is marital history. Age and what are the money at one, you have to identify the item, and you have to take the details of the spouse and the marital adjustment, sexual adjustment, and is there any extramarital relationship information you have to elicit from your client, right? Or any habit or addiction like substance abuse, mobile phone addiction, information you have to take. Next is pre-morbid personality. So what is pre-morbid personality? It is very important column, taking pre-morbid personality information. Pre-morbid means when your client is facing the problem. It is when the morbid. I am highlighting the portion. Morbid means the episode of the illness. Morbid means the episode of the illness. Okay, so before the illness, what are the personality factors the client has? Okay, so what are the attitude, what kind of attitude towards the self, whether it is positive and whether it is negative, you have to ask the client. Okay, and whether the child is sociable or not, before the illness you have to ask, because sometimes depressed patient, I already mentioned that presenting complaints that the patient may tell that does not want to interact with others. So while in a morbid condition, the sociability is decreasing, but before the illness episode, whether the client want to interact with other or not, you have to identify, you have to take a note. Okay, so for taking the details, pre-morbid conditions, you can ask the question to the client and their informant also. And the responsibility taking strategies, predominant mood. Okay, and the attitude towards criticism, maybe sometimes you can see that the client is very sensitive towards criticism, or they can take the criticism more sportingly. Okay, so what are the attitudes towards criticism? So you have to ask in pre-morbid condition, not the morbid condition. Okay, what are the moral values, what are the adjustment factors, and what are the hobbies and interests the person was having. You have to take a note before the pre-morbid while pre-morbid personality column. Okay, so these are the very important factors. So what are the changes are noticed in morbid condition, and you have to notice. Okay. So this is all about the case history taking. Is there any question? Please ask, because case history is very important thing. It will make you to understand the provisional diagnosis, and on the basis of diagnosis you have to plan the assessment program and further counseling strategies. So please ask any question, or any you need any detailed elaboration, please ask. Abhishek, you want to
Yes.
say something?
Yeah, ma'am.
Yeah, please.
Ma'am, this figure is okay. Elements means attitude, awareness, self, sociability, responsibility, then attitude, moral values. मैडम मतलब बस बट प्रैक्टिकली जब हम देखते हैं मैडम वो बिहेवियर और उसका जो जनरली कोई इंटेलिजेंट होता है तो वो बताता तो बहुत अच्छा है, लेकिन प्रैक्टिकली वो हमको देखने को नहीं मिलता मैडम.
इसीलिए आपको इंफॉर्मेशन मतलब एडिक्वेट है कि नहीं, आपको इंफॉर्मेंट से भी पूछना होगा.
क्रॉस, हाँ, उनके फैमिली से क्लियर होता है, फ्रेंड सर्कल से क्लियर होता है.
इसलिए मैंने स्टार्टिंग में बताया ना कि इंफॉर्मेशन रिलायबल है कि नहीं, एडिक्वेट है कि नहीं, कोरॉबरेट कर रहा है कि नहीं. आपको वो चेक करना होगा सेशन टू सेशन. कैसे चेक करना होगा? पेशेंट से भी आपको इंफॉर्मेशन लेना होगा और इंफॉर्मेंट से भी लेना होगा. ठीक है, इसके हिसाब से आप जान पाओगे कि हाँ जो पेशेंट बोल रहा है वो सच में कोरॉबरेट कर रहा है कि नहीं इंफॉर्मेंट के साथ.
मैडम मेरा भी एक केस हुआ था मैडम, मैं उसमें बताता हूँ. पेशेंट काफी इंटेलिजेंट था, पढ़ा लिखा अच्छा, तो काफी हायर पोस्ट पे था. तो उसने जो एक्सप्लेन किया इतना इमोशनल, इतना बढ़िया किया कि हम बिलीव कर सकते हैं कि मैं इस वजह से डिस्टर्ब हूँ. जबकि प्रॉब्लम वो नहीं थी. उसके जब पड़ोसी से पता लगा, मतलब ना उसके घर वालों ने कुछ कहा, मतलब भली बता रहे थे, सब घुमा रहे थे. लेकिन जब उनके पड़ोसी से पता लगा तो उसने बताया कि प्रॉब्लम ये है कि वो ओवर ड्रिंकिंग का उसने बोला नहीं, ओवर ड्रिंकिंग की वजह से उसको प्रॉब्लम होती है यूं. और जो पॉलिटिकली उसको जो पोस्ट मिलनी चाहिए वो नहीं मिली, उस वजह से फ्रस्ट्रेशन है. और जबकि उसने मुझे फैमिली प्रॉब्लम बता के क्लियर किया यूं. ये इस वजह से मतलब मैं उसको सोल्व कर पाया, जो रियलिटी बता पाया. लेकिन वो अभी तक भी बिलीव करने को, मतलब उसका जो बिहेवियर सब बता, पड़ोसी बता रहा, लेकिन वो पेशेंट रेडी नहीं है उसके लिए.
अच्छा,
थैंक यू.
Okay, anyone else who want to ask anything or any detailed elaboration want?
Ma'am, I just need one clarification. In the history of illness, the first point was precipitating factor.
Yes.
Which you explained that the main factors behind the problem.
Yes.
What exactly the patient is feeling. I understood this, but can you just elaborate it more with an example?
Okay. Like, so these are the complaints we have written, right? Okay, so like feels slow, does not want to interact with others. So these problems, right? So why the problems have been noticed? Why the problems started? You can ask your patient. Then patient may report that 3 months ago, I want to pursue for higher studies, but I cannot qualify the entrance exam. Right. So after the incident, I feel very low, does not want to interact with others, and constantly thinking my failure experience. So I cannot sleep well at night. Okay. So these are the causal factors mainly noticed by the client. So these are the you can write this in precipitating factor.
Okay, so precipitating factors are basically those incidences
Yes,
of the client. Okay, ma'am.
exactly. Anybody else? Okay, so if no one has any question, then next part, that is on mental status examination, will be covered by Priya ma'am. Priya ma'am, so over to you. If you want to say something more about case history, so you can also say and continue your portion.
No, I don't have much to add. You have covered it beautifully and have covered it in much detail with so many examples. So I don't think we have enough time. So I'll complete the MSc very quickly. So please make me host.
Yes. Done.
Thank you. I'll share the screen now.
मैम एक चीज शेयर करना चाह रहा था मैं. हेलो.
Abhishek, we will discuss your experience later because
yeah.
we have very brief time. We
Yeah,
will
yeah.
listen you, but let Priya ma'am
As you
describe
wish.
the.
Yeah.
Let him share. I'm trying to share my screen meanwhile.
Abhishek, you can share. Priya ma'am allowed you. Abhishek,
Yes, ma'am.
share your experience.
यस मैम. जो मैं पेशेंट की अभी बता रहा था मैडम, तो जब मुझे सब चीज पता लगी तो उसने एक्सेप्ट कर ली, है ना, कि वो ड्रिंकिंग करता है, उसका बिहेवियर में चेंज आ रहा है, ये मतलब डेटा क्लियर हो गया. लेकिन कुछ चीजें जैसे मैडम जब भी हम ट्रीटमेंट करने जाते हैं मैडम, अप्लाई करते हैं, तो जब वो इंटरनली चेंज होता है तो बड़ा डिस्टर्ब होता है मैडम उस समय कि ये इन्होंने कैसे फाइंड आउट कर लिया. हेलो. ये चीज मतलब मीन्स में बुक्स में मिलती नहीं है मुझे, कि जब वो उसका बिहेवियर जो चेंज होता है ना मैडम, कभी पॉजिटिव कभी नेगेटिव. हेलो. यस मैम. और जैसे हम सॉल्व करने मतलब क्लियर हो जाता तो वो एक्सेप्टेशन नहीं आता मैम. इसलिए फिर बहुत सी बार मतलब हम पेशेंट को वहीं छोड़ देते हैं. मतलब मुझे बहुत सी बार केस छोड़ने पड़े क्योंकि वो रियलिटी सामने आ जाती है मैडम उसकी खुद की, तो एक्सेप्टेशन नहीं हो पाता, तो फिर वो चेंजेस नहीं कर सकता अपने.
That means consistency is lacking, na? In first page, I mentioned that consistency you have to know. So that means consistency is lacking.
ओके. मीन्स मैडम जैसे हम काउंसलिंग कर अलग अलग वीक में और फीडबैक भी लेते हैं, जैसे मतलब हम क्लोज बिल्कुल क्लियरिटी पे आते हैं तो वो मतलब आउट कर जाता है पेशेंट जनरली.
That means his motivation in that, not that way. The client is not motivated.
Okay.
Can you all see the screen?
Yes.
Okay, so what do you know about mental status examination? Anyone? What do you know about mental status examination?
Ma'am, mental status examination, as the word says, that mental examination, the description of patient's mental state and its behaviors.
Okay. Right. Anyone else wants to add to that?
यस मैडम, मेंटल स्टेटस एग्जामिनेशन में मैडम प्रैक्टिकली जो मैं फील कर डे नाइट, तो इसमें भी डिफरेंस आता है मैडम, और जो क्लाइमेट चेंज होता है उसमें भी डिफरेंस आता है मैडम।
बिल्कुल बिल्कुल।
और मैडम कभी कभी तो जो मौसम चेंज होता है उसमें भी हो रहा है, मीन्स जैसे अगस्त में जो बारिश के टाइम की बात है उसमें अलग हो जाता है, और जो ठंड में दिसंबर में चेंज हो रहा है। तो कभी कभी जो प्रैक्टिकली जो देखा गया, लोग कहते थे मतलब कि ना ये अंधविश्वास होता है, चांदनी रात में ज्यादा होता है या फिर अमावस्या, तो उसमें इफेक्ट आता है मैडम पेशेंट्स को, जो मैं महसूस कर पाया हूँ। उसको भले वो धार्मिक वो चीज बता दी, लेकिन उसको प्रॉब्लम होती है मैडम उसमें।
हाँ हाँ। Okay. Anyone else want to add to that? No one? Okay, then let's talk about mental status examination. अच्छा, आप सबने कभी भी at any point of time, if you went to a hospital for something and before any diagnosis, did they give you certain test कि blood test करवा लो, X-ray करवा लो, ये करवा लो, वो करवा लो, 3 to 4 series of tests before they can come up to a diagnosis?
Yes, ma'am.
What do you think they're trying to do with the help of those tests?
On the basis of these tests, they will decide what medications are to be prescribed to us.
Okay. Medication के अलावा what all the things the doctor is aiming for?
They will get to know exactly what the problem is.
So the basic idea of doing any assessment or any examination, a series of tests, is to gain more information. Okay. So through mental status examination, so basically mental status examination is an integral part of any interview, since we know that when we are trying to assess or when we are trying to gain information about our client, so the moment the client enters into the room, जिस moment से वो हमारे room में enter हो जाता है, or the moment we start having our very first session, very first interaction, from the same moment you start gathering information about the client. So any kind of observation before even talking to a client, any kind of observation will reveal important information such as grooming kaisi hai, what is the hygiene level, what kind of behavior you can observe, what is the level of interest, if the person is conscious or not, or how the person is interacting with the surroundings. So there are so many things you can by which you can gain some information about the client. So briefly, the mental status examination is an integral part. It records only observed behavior, cognitive abilities, inner experiences expressed during the interview. And iska purpose kya hota hai? What is the purpose for conducting MSc? To assess as completely as possible the factors necessary to arrive at a provisional diagnosis, formulate a treatment plan, and follow the clinical course. So one thing is it, whatever the information we are trying to gain through MSc is observed, and all of them have certain parameters, such as these are some of the parameters, such as appearance, how does the client present himself or herself, what is the level of hygiene, or can you see the person has taken bath or the person looks out of hygiene, haven't taken bath, what is the level of clothing, it is in proper place, what is the level of nutrition, if the person looks healthy or malnutrition, the weight and the kind of alertness if you're talking to them, if what is the response time, if they're taking a lot of time in responding, or if they are sitting idle and not responding to it, they are lost. So through appearance, so these are some of the criteria or components of MSE. So the second is general behavior, examining the characteristic mannerisms, facial expression, eye contact, voice tone, general attitude, and you also have to take consideration of the gender, cultural, individual differences, and in the way these mannerisms are manifested. What is the kind of mood that person is showing? So the type and intensity of mood, are these emotional reactions appropriate to the situation, and the flow of thought. Note the rate and rhythm of the speech. If the client we are examining, we are talking to is slow, is speaking very slowly, is taking a lot of breaks, and is there is no connectivity in the thoughts. Suppose if a client is saying, yesterday I went to park, but in the dinner chicken was getting cooked, my cat ran off the window. So all these three things have no connection with each other. So you have to see what is the flow of thought. If is there flight of ideas, incessant rambling, kuch bhi bol raha hai without any, it does not make any sense. Disjoint thoughts, the content of thoughts. What is the content of thoughts? So if a person is talking about something, does it have any delusions and hallucinations that might indicate psychotic thinking? Are obsessions present in the thoughts? If a person is talking about something and a person is constantly talking about one thing over and over again, is there any suicidal ideation? And next, orientation, to see if the person is oriented to time, place, and person. If the person knows, if your client knows that what time of day it is, of if you are inside, you can ask them, bahar kaisa mausam ho raha hoga? What would be the time of the day? What is the date? What do you think is the day of the week? So by knowing all this information, that to know that the person knows where he or she is, what day it is, what he or she is doing in your company. Sometimes in the very severe cases, some of the clients do not even know what they're doing there. Who are you? So if you ask them, what are you doing here, आपको किस purpose से लाए हैं, they would say पता नहीं, हमको नहीं मालूम. And sometimes if you ask them what day it is, they would not even remember that what day it is, what date it is. It is going June, but they are in their head, it is still going March, or it is 2022, or they are still stuck in 2020. This can also be present in very severe cases. So all this information can be gathered through thorough observation, questioning, observing, and making sense of all the information which you have collected. Okay, so I'll go ahead. So briefly, you can, there are two ways of doing mental status examination. Before even taking the case history, you can quickly mark your observations on appearance, general behavior, mood, content of thought, orientation. Okay, but if you think that a person has a considerable decay in the thinking and the thought process, the orientation, appearance is out of place, then you might have to do a detailed mental status examination. And I'm sharing the format for the same. So this is the mental status examination. Can you see? PDF?
Yes, ma'am.
The mental status examination, appearance observed, behavior observed. Are you able to see the screen?
No, ma'am.
Yes, yes, ma'am.
Okay. So if you have to do it in very much detail, so if you have a normal client which does not have much a problem or does not have a very harsh issue, then a basic mental status examination on all the 5 components would be okay. But if you think the patient requires a detailed assessment and no one is giving much information, and if the person is coming to you for the very first time, then a detailed mental status examination would be helpful for you. So this is the detailed MSE, and these are some of the components you have to take into the consideration. So this MSE also helps you with the words or with the parameters, such as if you are talking about appearance, so all of the things are what you are observing on the client. No one else is telling you the information. So you have to be very careful in identifying the descriptors, such as what is the posture, what are the clothes looking like, are they washed, are they not, is the person stinking, or if the person is groomed, or you can see that the person does not look groomed. What is the posture, what is the gait. Okay, and then the next component is behavior. Possible descriptors would look like the mannerisms, the gestures, the psychomotor activity, how much the person is moving, what are their expression, if their facial expression are dull, if their facial expression are cheerful, if they are looking sad, if they are looking miserable, if they are looking confused, if they are constantly crying. So you have to understand what is the level of eye contact, if there is continuous eye contact, or if the person is not able to maintain the eye contact, ability to follow commands. If you ask them to write their name, are they able to get that command or request promptly, or if they have any compulsion, such as they are moving their hands too much, or they are moving their legs too much, or there are unnecessary movements in their body, right? So this is how you will observe the behavior. What is their attitude, if they are cooperative, if they are hostile, if they are open, if they are secretive, if they are evasive, such as evasive means they are trying to escape from the from whatever you are trying to talk to them. So if you are asking them what medicines did you take in the last day, and they are trying to escape that question altogether. Are they suspicious? If you're asking them question, they're constantly asking you, "Kyun puch rahe ho? What will you do with that? Why are you asking that? Are you recording me?" Or if you are checking your phone, who are you talking to? Are you going to tell my information to someone else? Or if they're constantly checking the surroundings, how they're interacting with the surroundings. Apathetic, that means their facial expression are blank, they are not showing any emotions. Easily distracted, if you're talking to them, if they're looking at the fan, they're looking at the color of the chair, they're fidgeting on something. If they are focused, if they're defensive. So these are the descriptives. The level of consciousness, if they are vigilant, if your pen fell down, are they able to observe that? If they are alert, if they are drowsy, lethargic, stuporous, asleep, confused, fluctuating. So you have to ask them some of the questions regarding their level of consciousness. So sometimes you would be able to observe, and sometimes you will have to ask certain questions. So in the first 4 components are something which you can observe, and in the 5th component you might have to ask certain questions, such as what is your full name. Sometimes they would only give their first name. Sometimes they would only give their pet name, such as Bhola naam hai mera to, my name is Bhola, but his full name is Bhola Ram Meena or something. So you have to ask them the full name. to understand their level of orientation. Where are we? To ask them if they were observant enough to identify the floor, the building, the city, the country, the state. Sometimes our clients are referred to us from different state, from different city. So sometimes it is good to ask to know the orientation. Where are we? Which is this floor? Did you see the color of the building? Which city you are in? Of what is this country? What is this state? So yes. What is the full date today? The day, month, year, day of the week, season of the year. You have to ask these things. These things would look like that this is so stupid to ask a person, but if you are going to meet such clients who are losing orientation, they would give you they would give you responses like, such as, if it is summer going on, they are still like, yes, it is, winter is going on, it is going to rain soon, I'm feeling very cold. And this is very true. If a person does not have any orientation, would lose orientation on the very basic things. So if you ask them what is the today's date, they would also forget what date is it, what is the day of the week, and how would you describe the situation we are in. So if they say this is hospital, this is a room, मुझे पता नहीं क्यों बुलाया आपसे बात करने के लिए, I do not even know why are we here, why are we talking. So we have to provide them some information to identify their level of orientation. Next is speech and language. The quantity, such as how talkative they are. So if when we're talking about speech and language, speech means how they are speaking and what kind of language they are using and what is the nature of their language. Quantity means if they are talking a lot, talking too much.
Ma'am, PPT not moving.
This is not PPT. It is a PDF.
Oh, okay, ma'am. Okay.